If you've tried to search for a therapist recently, you've probably had the common experience of feeling like the whole process is kind of broken.
If I had a family member who needed therapy, I would tell them, go interview 3 therapists, pick the one that you feel most connected to, give them a go. That's the best advice we have out there. It's like, make sure it's covered by your insurance so it's not cost prohibitive, and then interview a bunch of people. That's sort of where the field is. And you might sort that list by gender. You might sort that list by interest level or, something like that.
We all know that it's so important to find a good match with your therapist, but the process of shopping one therapist and another can be so exhausting. What if there was a better way? We
take it on ourselves to find you the person, because that is one of the reasons we see people drop out of care. So one of the data points we're really proud of is we look at like sort of the 4th session retention rate. So how many clients make it to their 4th session, because there's industry data we can look at there. And our rate it's at 94% of clients make it to their 4th session, where industry standard is somewhere around 30%.
This is the Hardcore Self-Help Podcast. I'm your host, Dr. Robert Duff. Today, I'm excited to bring you Colleen Marshall from 2 Chairs, a company that's revolutionizing the therapy match process.
It's such a vulnerable thing to be in therapy, and then to have it not work, it's really defeating. And so we think it's not just about access, it's getting access to the right therapist. That's why we put so much emphasis on this matching and the consult right from the beginning, and then measuring the alliance ongoing, so that we're really making sure that you are with the right person. And if you're not, making that change so that you get to somebody that is the right person for you.
So make sure you're subscribed wherever you watch or listen. If you have a question for the show or a topic suggestion, send me an email to duffthepsych@gmail.com. And with that, let's jump in. Well, I have a guest for you guys today. I have Colleen Marshall, who is the Chief Clinical Officer at 2 Chairs, an innovative therapy company that we'll talk all about. We're going to talk about difficulties that a lot of people face in finding therapy, ways in which the current system might be not working so well, and of course, 2 Chairs' innovative approach. Before we get into it, I want to make sure that everybody knows I don't have any affiliation with 2 Chairs. They just reached out, and I thought it was a very interesting concept. So we'll dive in from there. How are you feeling today, Colleen?
I'm great. Thanks for including me. I appreciate being part of the conversation.
Where are you tuning in from?
So our headquarters is in San Francisco, but I work remotely out of San Diego.
Oh, okay. Your office has very therapist-y vibes. You literally have 2 chairs behind you.
Yeah, that's not intentional, but it ended up happening.
Love it. Can you tell me a little bit about like your history and experience in the field, even prior to getting involved in 2 Chairs? What are you all about in the field?
Yeah, sure. So I'm a licensed marriage family therapist by training. So started out of grad school really wanting to be, therapist behind the door, magic happens kind of person. Really quickly moved into leadership roles. Every time I tried to be just a therapist, I was sort of asked to take on a leadership role. So spent most of my career in clinical leadership. And most of my career in community mental health. So in a large nonprofit in San Diego for many years. And then also, ran a community mental health center in Kentucky for several years too. But I really started getting interested in innovation or startup culture probably in about 2012. I joined an organization that was looking to scale basically a service where we would call people who were facing end-of-life decisions and help them make value-based care decisions about what were they really wanting in their last year or so of life. Wow. And I loved that because I joined when it was a startup, it was past proof of concept, and I helped scale the organization over the 3 to 5 years that I was there. And I really loved that, but building out clinical cultures, building out clinical teams, building out quality measures, training initiatives, recruiting standards, things like that. So I've hopped around with startups a bit. I helped another company that was thinking about behavior change strategy from a more holistic behavior change approach using behavior economics. And I'm an expert in motivational interviewing, so a lot of my background has been thinking about how to apply that specific evidence-based approach into technology, into organizations, into implementation. Wrote a book about how you use it in leadership.
Can you give the top level of just like what motivational interviewing means, just as context for that?
Yeah, sure. So it's a conversation that you guide someone through that helps them decide whether or not they want to make a change in their life. So it's really focused on behavior change, on a target, on whether somebody is. So when we face change as a human, almost always we face it with ambivalence, which means you feel two ways about it at the same moment. And what MI helps is guide the client towards what's most important to them and what they believe is possible. And the solutions really come from the client versus the experts lecturing or telling or directing you into what you want to do.
This is where we get the like stages of change, right? Like where somebody is in their path in terms of change, and then you trying to kind of meet them there and figure out where they are.
Yeah. So stages of change was Prochaska and Di Clemente came out at the same time as motivational interviewing. Motivational interviewing was Bill Miller and Steve Rolnick. And so they came kind of together on the world. They're slightly different. The application, I mean, the concept of guiding someone through change is similar, but how you think about it and what you're doing specifically as a provider is different.
Gotcha.
We're really listening for, like in motivational interviewing, we talk a lot about ambivalence and spirit, the way you are with a client, and also change language. So what specifically are you listening for in the conversation? That can help sort of grow motivation to for the client to want to make a decision about whether they want to change or not.
Okay. So, I mean, hearing this, I can see a lot of the seeds of why you might be working, with a company like Two Chairs, because you have a heavy focus on that relationship, with who you're working with, and then this interest in scaling, companies that are trying to make, innovative change. Do you have a business background or anything like that? Or did you just stumble your way into this?
Yeah, I stumbled my way into that. I always say I was super lucky that when I was early in my career as a manager, my supervisor was Dr. Orville Kuntz, who had a PhD in clinical psychology and also an MBA. And so he sort of saw it as his responsibility to train his managers in always thinking about clinical excellence and business optimization at the same time. So I learned a lot under him. Read a bunch of Harvard Business Review books and articles and things like that. But no, I don't have an MBA, but was sort of, when you oversee large programs, you're sort of forced into understanding budgets and P&L and marketing and all of the things. So, if there was like a, the way we give someone an honorary PhD.
Yeah. You have an honorary MBA from the School of Hard Knocks.
Yeah, exactly. Yeah.
Right. So how did Two Chairs come into the picture? Were you involved with the origin of it, or did you come on later?
Yeah. So I think I join organizations when they're past proof of concept and are ready to scale. That's my sweet spot. One of the things I like to help people do, but me personally also, is just know what you're good at and when can your strengths really support an organization. And I think that's my sweet spot, is when an organization's ready to scale. So I was recruited for the role. I was actually working in a digital cognitive behavioral health company at the time, which I actually enjoyed. It's a company called Silver Cloud, was acquired by Amwell. Really nice model that they had, and I was overseeing all the coaching services. But I joined Two Chairs because I really believe in their mission. I was really impressed with the leadership team. And also this matching component that Two Chairs really has. I haven't seen anything like it in the field. I know people say they do matching in the field, but they really don't do it the way Two Chairs does. And I know as a therapist that getting the relationship right from the beginning is critical. We know Therapeutic Alliance is hugely connected to patient outcomes, and I don't see the field paying attention to that very much. Minimally, people will do things like match on gender or match on identities or lived experience or something like that. But I like to parallel it a lot to dating. Who I want to date and who you want to date are very different people. Even though that human is probably an amazing human, I don't want to date them, and you don't probably want to date the certain same people I want to date. And therapy is kind of like that, because you've got to have that bond, you've got to have that feeling heard and trusted and pushed a little. And so each one of us, it's different for each of us about what that looks like. And we take for granted, I think, in the field, especially when I was over community mental health, we sort of expected therapists to be generalists and see everybody
Whoever
that walks in the door.
door.
Yeah. And we as therapists know I'm not good at everything that walks in the door. There's certain populations I'm better at, and there's certain people that I connect with better. And we know that too. So in my mind, why Two Chairs was so interesting to me, it's a win-win for both the therapist and the client. So therapists get to really sort of craft what type of panel they know they're good at. And so then they have more joy in their job. They feel more successful. They feel like they're helping people more. And then the client gets matched to someone who actually is good at what they are coming in to see, and someone that really does want to work with that specific type of person.
Yeah. So we jumped ahead a little bit in terms of talking about Two Chairs itself. So it can you describe the platform, like what it actually is, and how it's different from, say, something that's more traditional, like it's searching for somebody in Psychology Today or going and doing a BetterHelp or something like that?
Yeah. So I would break it down to really two main components. Is Two Chairs built on first is getting the therapy or the match, the Therapeutic Alliance right from the beginning. And so your very first appointment with Two Chairs is with a licensed clinician that really helps assess. You do sort of a preliminary diagnosis and a preliminary treatment plan, but you're also assessing for what type of therapist would be best for this client. And we have about 300 different factors we're considering that we put into an algorithm, and then there's a match made. And then we track the second piece I would say is we're a measurement-based care organization, because the research is also very clear that when you use measurement and treatment, clients get better faster and their outcomes are more reliable and sustainable. So measurement is part of everything we do. It's in our DNA. About 94% of all patients fill out our measures every single session they come in to care, which is really high. The industry standard is pretty low on being able to collect that a level of measure. And I attune that really too, because our therapists, our clinicians understand our clinical model, which is that you get the match right, you look at the relationship all along, and then you measure to see how treatment is going, and you use that data to adjust care as you're going through. And then the clients get visibility into their measures, the therapists talk about them in session. And the measures we're looking at are depression, anxiety measures, quality of life measures, and also alliance. So part of when I'm saying we get the match right, we get it right from the beginning, but then we're watching it all the time, because we know there can be ruptures in treatment, there can be things that happen, and we want our therapists regularly talking with the client about not only are they making progress towards their clinical goals, but also how is this relationship going, So I would say that's the two things I would say that we're different is we really think about getting the alliance and the therapy match right from the beginning, and then we measure things to make sure that both the client and the clinician are actually paying attention to whether clients are getting better, stagnant, or ready to graduate.
I've, obviously seen versions of using measurement in therapy, in community mental health, for instance. I know a lot of times there are maybe quality of life measures or anxiety, depression and such. The alliance, so that the therapeutic relationship between you, measuring that continuously as you go along, seems a little bit different. And if I'm thinking from kind of like the client side, I put that hat on. That sounds a little scary. Like I would be intimidated, like, oh, they're going to know how I feel about them week to week. What do you have to say about that? Yeah.
And so that's part of why we know that therapists in general don't do measurement. I think the most recent research was something like 20% of therapists actually use measurement in treatment. So we take it on ourselves to train them. So when they come in, they go through a large onboarding program, but then also we do ongoing sort of fidelity training to it. And part of it is teaching therapists how to bring up that container in session. Because what we want the clients to know is if you give me a low score, it's a gift. It's actually saying you trust me enough to let me know something didn't happen last week. And we want them to respond that way. So if a client does give me our scale is a 5 scale. So if they give me a 3, I don't want to come in the next session being like, what the heck? Like, you gave me a 3.
Why'd you give me a 3?
You gave me a 3 and I thought we were great. Like, why are you mad at me? Like, then you're not going to have a robust conversation. So if you approach it instead with, thank you so much for being honest. It sounds like last session didn't go as well as you were hoping for. Could we talk a little bit about what you were looking for? What wasn't right on target? What do you want more of, less of? And then I can adjust my style and approach. And we orient clients to that from the very beginning. We let them know, even with the match, that we're going to do our best in finding you a match. 98% of the time we get this right. But that does mean 2% of the time we don't. And so if the relationship isn't feeling right, Please let your therapist know they're used to this. They'll adapt their care, to what you're looking for, because it's, everyone's different and unique. And if for some reason, if that isn't working for you, come back to the consult clinician and let them know, and then we will find you somebody different. And we're trying to make it as safe for clients as possible. The other thing is the therapists are trained to observe the non-behaviors and then talk about the data. So for instance, even with the clinical measures, someone can be scoring really high, saying I'm doing really well, and the clinician's like, but every week you're telling me that you're not getting out of bed and you're not going on walks, and so let's talk about how the data and what your presentation isn't matching. So let's talk about what that's happening there.
It seems like it also, do you work on the clinician side for the company as well? Do you do therapy through two chairs or just the leadership stuff?
Yeah, I have. I've done consults. I have not yet taken on clients yet, but I have done consults.
Gotcha. It seems like one of the things that having that kind of two-sided assessment and being very immediate and bringing it up in session can help with is the feeling of like the therapist is up here, the client or patient is down here, that sort of power dynamic, where instead it's like, it's not exactly egalitarian. Obviously, there are different roles, but you are talking about the same thing and working on it together in a more of a productive way, it seems like.
Yeah. So really being as collaborative as possible. And this is one of the things when I was talking about motivational engineering, is one of the core spirits of MI is collaboration, and really understanding that there's two experts in the room, and it's the two experts in the room that are going to solve this problem that we have in front of us. So it's the therapist leaning on their expertise and the different treatment modalities that they're trained in to help the client along. But the client's the expert on what really is most important to them and what they think is going to work and what they think they're willing to try and give it a go. So both of those expertise have to be supported for clinical work to really be effective.
Yeah. Can you talk a little bit more about, so the idea of matching between, client and therapist? How do we know that that's important? Why is it important? Tell me just like a little bit more about that.
Yeah. So the way we built outmatching is we looked at all the literature and the research on what does matter in a therapeutic alliance, what does matter in a relationship. And then really we're asking clients for their feedback, and the clinician is listening for what the client says, but also behaviorally what's happening in session. So let's say a client says, I really want a structured person who gives me a lot of advice and guides me, but yet they're responding negatively to the clinician suggesting something in session. Then the therapist is, basically sort of assessing that, like, okay, they're saying this, but it looks like they sort of bristle at that. So let's figure out what the right clinical presentation might be. But the things we're looking at is, first and foremost is what are they needing for clinical treatment? So, what are they coming in for? What are we needing to treat? And
do
making
they have OCD or PTSD, what have you?
Exactly. Yeah. So and there could be, someone might be coming in for depression treatment, but they also have, they're neurodivergent or something. And so we need to make sure the therapist is able and clinically trained to handle those things. So that's first. That's why we do sort of the preliminary diagnosing and treatment planning. And then we get into just the different factors that the research says about, like, what are they looking for in a provider, stylistic preferences. There's identity preferences too. For some folks that matters a lot that they have somebody that, is representative of their experience. So we look at a lot of different factors, and then we put that into the algorithm, which is like, sort of sorting and prioritizing and weighting different things that produce a better match. And then because of that, then we're able to circle back and then watch outcomes and see how the outcomes are affecting that as well.
Does that algorithm continuously change as you gather more, outcome data, or is that, did you land on something that works really, really well, and that's kind of what's running with it?
So what I would say is my research innovation team and our data team they're the ones that are updating the algorithm and the weighting. So what we're looking at is the research and the outcomes of our population, and then adjusting priorities based on that. So it's not the algorithm itself is learning, but the company and the system is learning because of all the data we track. Also, we're easily able to sort of see the decision we're making and how it impacts client outcomes.
Yeah. So one thing I'm thinking about is, like, that's very different from the system that you would have. Like, right now, if I were to go look for a therapist, I might go on Google, I might go on Psychology, whatever, find, therapist, that treats anxiety. And, I'm going to have a huge list of a million therapists that say they specialize in a million things. So what have you heard from patients about sort of how the experience might be different from one to the other?
Yeah, they really, really love it. Both the therapists and the patients both say this is their number one thing that they love about Two Chairs is the matching, because of what you just said. So, if I had a family member who needed therapy, I would tell them, go interview 3 therapists, pick the one that, you feel most connected to, give them a go. That's the best advice we have out there. It's like, make sure it's covered by your insurance so it's not cost prohibitive, and then interview a bunch of people. That's sort of where the field is. And you might sort that list by gender. You might sort that list by interest level or, something like that. But we see it as, we think the industry right now focuses a lot on access to care, it's just getting someone in care, which we think is important, of course. We know from a motivation perspective, when someone raises their hand for care, you want them in care as soon as possible. So we have that consult appointment within 2 business days because we want to make sure as soon as you raise your hand that you're talking to somebody and getting hope, really, is what we're trying to instill. But then we take it on ourselves to find you the person, because that is one of the reasons we see people drop out of care. So one of the data points we're really proud of is we look at like sort of the 4th session retention rate. So how many clients make it to their 4th session, because there's industry data we can look at there. And our rate it's at 94% of clients make it to their 4th session, where industry standard is somewhere around 30%. So we're about 6 to 7 times greater. And we think it's because of that. Because what happens is out in the real world, people therapy shop, and then they might have 1 or 2 sessions with the therapist that isn't a good fit for them. And then they make up the story that therapy isn't for them, that therapy just doesn't work for them, which really is, I parallel it again to dating. It's like I dated a bunch, but I didn't find my life partner right away. But I didn't assume that I'm not, worthy of a life partner. I just assumed I hadn't found them yet. And I think it's the same for therapy. It's like people give it a try. They try once or twice. And it's such a vulnerable thing to be in therapy. And then to have it not work, it's really defeating. And so we think it's not just about access. It's getting access to the right therapist. That's why we put so much emphasis on this matching and the consult right from the beginning, and then measuring the alliance ongoing, so that we're really making sure that you are with the right person. And if you're not, making that change so that you get to somebody that is the right person for you.
So really trying to capitalize on that moment of, yes, I'm raising my hand for help, like you said, because it can be, especially with a lot of issues that people might be looking for help with, say depression, it can be very demotivating to not find that match right away. And I hear a lot from people of, I'm so tired of just telling my life story over and over again. It's like that. Should I make a PowerPoint so that I can do this with each therapist that I see? So you're trying to really take that burden off of the person and try to get it right, at least as close as you can the first time.
Yeah, absolutely. And then really being clear about what the goals are of care too, because that's the other thing I think people. It's easy to get into therapy and just sort of talk about your week, and then you're not really making progress on treatment goals. And so being really clear from the beginning that we found the right person, and are we clear about what you're wanting? Like, what does success look like? If you and I are successful here, when would you be ready to graduate? What does that look like from the beginning, so that clients, again, have something they're anchoring on for hope, that they know, because, you and I know as clinical people that when you're experiencing anxiety or depression, a little improvement doesn't feel like improvement, because you're still having a panic attack every 3rd day or whatever, but you're not having it every day now. So that's progress. And so really measuring and helping clients know you're making progress, because those panic attacks are every 3rd day instead of every day now, is important. So clients can see hope and can see that they're getting there, even though they still have some symptoms that are uncomfortable that they don't want.
Yeah. To me, it almost sounds too good to be true in a way, if I'm being honest, because this platform, the way you're describing it, addresses so many problems with therapy, right? Finding not just anybody for therapy, but finding the right person. Also, therapy not just turning into check-in sessions where somebody feels okay and kind of happy, but nothing occurs in the context of therapy. So why hasn't this emerged already? Why aren't other companies doing this, do you think?
Honestly, because I think it's hard, because you're changing the culture, both the client expectation and the clinical team's expectations. And you have to, I'm a big believer in implementation science, was trained in that to really understand. But to implement something, an evidence-based approach, we consider MBC or a measurement-based approach, and we let therapists choose the other evidence-based approaches they're using in session. So you could be an ACT therapist, but you have to do MBC at 2 chairs, or you could be a CPT therapist, but you have to do MBC also. So if you think about it that way, when we're implementing an evidence-based approach, you have to implement it at every single level. So you have to implement it at the policy level, the procedure level, the performance management level, your technology level, your data level, the clinical training, and your hiring. So when we first started implementing MBC, there were some therapists in our organization that actually left because they didn't really want to think about measurement and care. They wanted to do something different. So we had to change our recruiting expectations and our screening to make sure that the team we're bringing in is open to this approach. So it just, and then, we have a really amazing product team that has built out really beautiful care platforms that make it easy for the therapists also to see this data and interpret the data. So there's a lot of sort of decision support built into the product that help clinicians see it. What I would say is it's hard to change that entire culture and to make sure all of those things, Dean Fixon's research is the one I would pull up right now and say, like, did we check all these little things on the triangle and we've hit them all? Where I see other people in the field that are using measurement, it's like they have one part of it, like they require collection, but then there's not the training, or there's not performance management around it, or there's not, technology that makes it easier for the therapist having to figure out like how to look at paper charts or something. So you really have to do it all, I think, for it to become part of your culture. And it took us a few years to get here. We certainly didn't start. I've been with the organization about 2.5 years now, and it's taken us that entire time to really get it to where it is now, where you can tell it's in our DNA. I'm in meetings where clinicians unprompted are talking about it. So you can just tell that we've turned the corner, and it's now just part of who we are and how we do it.
Do you know how many clinicians are in the network?
We have 500.
500. Okay. Yeah. Because it seems like one of the big things that's difficult is how to scale that while still being as selective and careful, right? Because a different platform, it is much more of a shotgun approach where they're not necessarily going to be as on people about making sure that they're implementing the measurement-based care and integrating it, because they don't want to lose clients and then lose money and then not survive as a company.
Yeah, absolutely. And, and that's part of one of the reasons we're a W-2 employer. Some of the other folks out in the field are 1099s. But why we're W-2 is because then we have the space to really train people and provide the right supervision and the right...
Explain that a bit.
So W-2 employees are, that means that they're fully salaried with us. And so they have, they're paid for their time in training and admin time and wellness hours. So we can make sure that they have a balanced week, where 1099 employees get paid only for session. And I mean, they could get paid for other, small things like, attending a training or something like that. But they're really independent, and the law makes it very clear that you can't really direct them. Like, they need to be independent practitioners doing what they think is right. And so you can't influence them as much. When a W-2 employee, we're able to sort of work together. One of the things I would say, if you ask 2 chairs employees now or therapists, our culture is something that we're really proud of, because we've built that collaborative sense of really listening to the therapist. We talk a lot about the clinician experience being, it's one of the things I'm held to as chief clinical officer, is because we need to make sure that we're taking care of the caregivers, because they're the one doing the care. And so when you have a W-2 employee model, you can do that. We can make sure they have balanced weeks. We can make sure they have wellness hours. We can make sure they have specialty training, specialty consultation groups, all of those things. When you have a 1099 employee, you just don't have as much influence there. So that's one of the reasons we anchor on that, is because it's important.
And a 1099 independent contractor is going to be more motivated to take whoever does come through the door, because they just need to make money, right? You need to see as many people as possible, essentially, in a lot of cases.
Yep. And the other thing that we focus on is also efficient care, which means graduating people and not just keeping people in care forever, where like if you're in private practice, for example, you're motivated to keep somebody in care forever, because if you and that client do well together and the client wants to keep coming and someone's willing to keep paying for it, there's no motivation to actually graduate the person. For us, though, graduation is the goal, because we see it as we're trying to create access. So our mission is to provide exceptional mental health care to all. And to do that means you've got to create space. Like you have to let people get optimal treatment and then let them go on with their lives. And they certainly can come back if there's something else that comes up, or, if something, comes back into the picture. But just keeping them in care for maintenance care or supportive care, or the thing you were just mentioning before, of just coming in and chatting about your life, it's not a good use of their money/time. And I also think it sends the wrong message. It's sort of sending a dependency message, like you have to have a therapist in your life to be a functionally successful person. And we just don't believe that. We believe that therapy is treatment, and you come in and you focus on goals, you achieve those goals, and then you move on in your life. And then if you need treatment again, you come back, just like if you were needing a physical therapist or something.
That's kind of the broad messaging, though, I think right now in society, social media land, right? There's kind of this concept, well, everybody should have a therapist. Everybody should be in therapy. And it sounds like you're saying, potentially, everyone should have access to therapy and use it when they need it, but not everybody should be in therapy all the time for no reason.
Yeah, totally agree. And part of that also is because if you're paying for care yourself, then you can, create the rules. But most people are coming to therapy through insurance, which I actually think is a benefit, because it means that it creates access that people couldn't normally have. Because most of us can't afford the fee of seeing a private therapist weekly for weeks on end. Like most of us don't have that amount of resources available to us. Yeah. So when you're dealing with insurance, it allows clients access. It makes it affordable for them to be able to come to care. But it also does mean that it needs to be medically necessary. There needs to be a reason you're seeking treatment, not just, a hired friend,
Sure. A hired friend. That's a good way to put it.
Yeah.
Now, that focus on graduation, on trying to get somewhere and have a measurable outcome to therapy makes sense to me. Do you also have people who end up being there for an extended period because they are working on progressively deeper issues, for instance, trauma, things like that? Yeah.
So we leave it in the clinician's hands to decide. So we give a lot of data support and a lot of decision support to the therapist to say, here's what the data is saying. And if clients are stagnating, you really should be looking at, are you providing their treatment, or is there something else we should be providing for them? So, do they need a psychiatric referral or something? But really, it's up for the clinician to decide when someone's ready to graduate. So there are definitely times where somebody is either they're dealing with major issues, or there's many things that keep coming up. So, for instance, someone who might have been ready to graduate and then, their partner dies. That's somebody that you now need to work through grief, because this just happened in the middle of treatment.
You're not just going to say, okay, well, time's up.
Right.
See you later.
Yeah. And when I was early on, when we were starting to talk about efficiency of care and helping therapists really think about that, just as an example, it was during COVID or near the end of COVID. And we had a nurse who was working in the ICU as a COVID nurse. So that's someone that probably should be, as long as she's feeling benefit from this, let's just keep her here until this crisis sort of settles down, sort of like you would have if, you were in the military or something dealing in active combat. That kind of support, it makes sense. So we don't have there's, some providers that have time limited sessions, you get 12 and that's it. That's not us at all. We definitely look at, is somebody getting better? What's the data saying? Are they stagnating? If they are, that's probably time to assess how treatment is going. And if somebody's subclinical or has made meaningful improvement over X amount of weeks, it's probably time to start talking about graduation too. So that's how we kind of think about it. But that does mean there's people that stay in care longer because they're dealing with more complex stuff.
Yeah. And I imagine sometimes they pivot as well. If their goal is, okay, I'm having panic attacks at work and it's making me call out sick, and they solve that problem. But then once that's resolved, they realize, the origin of this is really XYZ, and I would like to dive into that. Can they pivot if it's appropriate with that clinician?
They can. When they can also ask for a rematch. So let's say that example, let's say if somebody was dealing with anxiety, and their treating provider is an expert in anxiety, but then they realize it's actually trauma is the origin, then they could ask, the therapist and then would decide if that therapist should be the one to continue the treatment or should they be looking for a trauma therapist,
I can see where the employee W-2 model really facilitates this, right? Because on the client side, often it feels scary to address something that feels like, okay, maybe I need a different approach. Maybe I should switch therapists, and they feel bad about that. And then on the therapist side, as you said, maybe in private practice, that is a risk. That is there's an income risk to letting go so many people if it all happens at once. So in this case, it's encouraged to talk about that and to see if there might be, a match that's better for this period for you, et cetera.
Yeah. Absolutely. And the graduation part, I think, is also tricky for clients because they don't know how to fire their therapist. Like, how do you say,
right.
Are we done here? And
yeah, it's not just to go, well,
yeah,
it's been real.
Right.
Okay.
Yeah. And that's why you'll see sometimes clients kind of ghost their therapist. And then, they're walking around with guilt out there about I wish I'd been able to say goodbye. This person helped me a lot. But it's because, they don't know how to say, I think we're done here. It takes a lot of assertiveness and boundary setting to do that. That's part of why we also see it as the therapist's responsibility to be checking in regularly, like, where are we at? How are we feeling? Are we, is it time to start talking about graduation or not?
Yeah, I have to imagine this feels so different as a model from what some people have experienced, because I get a lot of people, especially in my work doing neuropsychology, I do a lot of sort of assessment. And so I hear about people who have done therapy. I'm not their therapist, but they tell me about the experience. And there's so many people that this feels like a completely different beast to what, therapy means to them, which is that sort of hired friend model.
Yeah.
So it's great. It's great.
Yeah. We're definitely trying to change what the quality looks like out there. I mean, that's one we're anchoring on is getting, quality care, not just care.
Yeah. But on the clinician side, I imagine it's probably really gratifying for you too, you've probably built some serious skills in community mental health of doing a lot of intakes, getting to know people, and sussing out what the major issues are. But then in that setting, you don't really have a lot of options. You kind of go, okay, well, you're going to see a therapist now. Whoever you get is pretty much who you get with some minor exceptions. But in this case, you can actually learn as much as you can about them and apply that to something very productive to get them matched with somebody that fits well.
Yeah. I mean, and that's part of why scaling is important because you need a large panel to be able to do that. I mean, that's part of why community mental health does struggle a bit because you don't usually have a huge amount of resources that you can refer to. And I feel like I'm bad-mouthing community health. I think it's an amazing safety net out there that they really are supporting.
Yeah, it's got to be there.
Yeah, they're definitely doing great work. But it does give us access to different ways of connecting clients to different kinds of expertise and personalities.
Yeah. Do you see this as something representative of the field broadly, kind of a change happening? Because, for instance, I talked to Patrick McGrath from a company called NoCD. It's an OCD platform. Mm. All the therapists are trained and very closely monitored on ERP, and they just focus on that in OCD. So it's very narrow, but for that reason, it's very effective for the people that need that. And this is similar, where it is kind of narrowing things down. Do you think this is a trend where we're going from broad, applicable to everybody, to a little bit more narrow?
I think it's sort of a yes and because I think there's a lot of generalists. If you look at 80% of the reason people join or need therapy is depression and anxiety related. And most of the time it's, anxiety needs medication as well. Depression needs medication as well. So there's psychiatry piece too. Mm-hmm. But if 80% of the people coming in need depression and anxiety, that's for example, one of the things we require for someone to work for us is that they can treat depression and anxiety.
Sure.
But then you start expanding out because not everybody can treat OCD. Not everybody can treat neurodivergency. Not everyone can treat trauma. Not everyone can treat eating disorders or substance use disorders. So I think it starts with the core of the population is probably pretty generalist in my mind. Mm-hmm. But then as you start getting into more nuanced mental health treatment, I can imagine it'll start being more structured or specific treatment modalities.
Yeah. What are some of the things when people think about matching or finding a good match for a therapist, I imagine they think of things like gender, maybe age, maybe approach or identity. What are some of the things that maybe people might not think about when it comes to matching that you guys implement?
Yeah, so it's the stylistic stuff. I think back even, I have sons of mine that are graduating from college. And back when I was in college, the dorm matching was rudimentary. And now they match on lifestyle. Do you get up? Are you a night owl or morning owl or whatever? And they have
really?
Yeah. And I think that's similar to therapy. Is think about the stylistic stuff. So do you want someone who's directive and gives you a bunch of advice, or do you prefer someone who guides you to sort of an answer and a solution? Do you like someone who's structured and wants to give you homework and he follows up on homework and is, more organized in that way? Or do you prefer someone who's a little more creative and free flowing and, intuitive in their approach? And trying different sort of styles, if you weren't coming to two chairs, is what I'd be looking at. Is it's almost like, trying on a dress or something. It's what do you like about the dress? What don't you like about the dress? Because it's really coming down to stylistic things. I don't like that this person interrupts me, or I don't like that this person is giving me advice. I don't really want advice. I want them to help me come to understanding what's happening. Or I don't even know where to begin. So I want someone who's doing a lot of psychoed and teaching me a lot of skills and having me reinforce the skills in session and, be more like a personal trainer than sort of a more conversational. Those types of things matter because we know it's almost like if you go to dinner with someone, who do you prefer to have a conversation with and who don't you? So some of that stylistic stuff is what I would look for sure.
The dress analogy there makes a lot of sense because, you might be like, oh, I love the style of this dress. The color is great, but it doesn't fit well.
Yeah.
Right. So it's I know I work really well with cognitive behavioral therapy. I'm all about those nuts and bolts, but this person, for some reason, we just don't work the right way. But that doesn't mean CBT is bad. It means that particular match isn't there. So what about somebody who has maybe some other factors that work well for you?
Yeah, absolutely. And sometimes it is even the trying different approaches. So maybe you've tried CBT 100 times, trying ACT and seeing what it feels like. Because, my sense of the general public is they don't really know much what's different, but they hear out there in the ether oh, my sister did CBT, so I should ask for CBT. But they don't actually know if CBT is helpful for them or not. So try it. And if it doesn't feel right, it's too structured for you, then let's try something different,
Yeah, that is a problem in our field is the alphabet soup stuff, right? DBT, CBT, ACT, EMDR, it's just all acronyms.
Yeah.
And people maybe have heard these things, but they don't really know what it means. For this platform, do you worry much about trying to educate people about what those terms mean, or is that sort of later and you just try to find a good match without really worrying about all the terminology first? We
definitely are listening. So it is not uncommon for someone to come in and say, I want EMDR or I want CPT, CBT. And what we listen for is, okay, so tell me what you're hoping to get out of that. Not
what does that mean to
what
you?
Does it mean to you? Exactly. So I want to, CBT is a great example of I'm really struggling with managing emotional regulation, and I'm having lots of panic attacks. So I just really want to work on skills to improve my panic attacks. Okay, great. Well, CBT, then what that will do for you is really thinking about how you approach the thoughts that come up when you're feeling anxious, and then teaching you some behavior activation skills that can help you feel better. Does that feel kind of what you're looking for? That's sort of what the conversation we'd have. And the person's like, no, I don't think it's about my thoughts. I think it's actually managing my emotions. You're oh, okay, so maybe actually somatic therapy is what you're looking for. So let's talk about what that feels like. And then, so we're sort of collaboratively creating what the client might be looking for, so that they're not disappointed that they thought CBT would do something for them that it doesn't actually do.
I like that a lot because it's how the hell are they supposed to know?
Right. Yeah.
They didn't go to school for this, and people, they go off what they know. And then from there, it can feel intimidating because they're well, I put in CBT and there are 2 billion CBT therapists that are popping up for me. Yeah. Okay, what now? Right. So that's really great. And I can imagine is such a more comfortable experience than being okay, well, tell me what you want.
Yeah, exactly. Yeah.
So I do have a question. Obviously a small, very small, if any, percentage of the population listening to this right now is already kind of doing two chairs. What would you say to people who are, going a more traditional route and maybe are finding that they're having trouble finding, a good match? How might they address that with their therapist, or do you have any advice for them in general, just based on what you've learned in this process?
Yeah, I mean, if they're already in treatment, I would just bring up to my therapist, how do we check in on progress? And the kind of progress that I would want to understand is, how do we talk about how the relationship is going? And also, how do we talk about whether the treatment goals are making progress or not? And I would just bring it to my therapist, like, how could we do that together? And hopefully your therapist will be able to guide the conversation about what feels right and structured for them. So maybe you check in, I don't know, every 2 weeks or once a month or something. So if I was in treatment already, that's what I would do. If I were not in treatment and I was starting to find somebody, I would just be paying attention to, what am I liking about this person that I'm meeting for the first time? And usually I would give someone like 1 or 2 sessions. And then if you know yourself well enough to know, like, I'm feeling heard, understood by this person, not judged by this person, and also a little pushed. Like, you don't want it just to be a warm hug. You really want someone that's going to challenge you a little bit, because you're trying to make change, which means that things will be slightly uncomfortable a little bit. But if they're pushing you too hard or too fast, or you're super uncomfortable, that's not a good fit either. I have friends in the educational space that always call it these learning circles. So there's your comfort zone, there's your learning zone, and then there's your challenge zone. And you want to be in that learning zone, which is like one step out of your comfort zone. But that's what I'd be listening for. And really, it's paying attention to yourself. Like, don't try to rationalize away what you're experiencing. If you really can tell this person you feel judged or something by them, or it's just not a good fit, that's fine. There's no judgment on that person. It just means that's not your person. And then try a second person. And, usually that's why friends and family, I would say interview 3 and pick the one that you feel the most connected to.
Yeah. And that's a great point about paying attention to how you feel, because you can look at somebody's CV or resume and say, oh, wow, they have great education. They've done this for so many years, blah, blah, blah. But then you get into the room or virtual room with them and you realize, like, the way they are reflecting things back to you, you're like, that feels a little judgy, or that just doesn't sit well with me. We're not on the same page. And so it doesn't really matter how good they are, in the field, if it doesn't feel right to you.
Yep, exactly. Yeah.
Can you tell me a little bit more now about, so with two chairs, where is it available? How, give me some of the logistics about it for somebody who's listening to this and might be interested in pursuing it.
Yeah. So we're in 3 states, and we do hybrid care. So we have offices, but we also have teletherapy. And so we're in California, Washington, and Florida. We are growing into other states, so we will be in more states every year. You'll see us sort of expand into that. But we also take insurance. So we have Kaiser in California and Kaiser in Washington, and we also have Aetna and Florida Blue. So if those are any of your insurances, we do take those insurances.
For anybody that's not in California, that's rare for somebody to be on Kaiser that's not from Kaiser. So that's cool.
Yeah. Yeah, they were our first partner, actually. They're a great partner.
I cut you off there. So you have you're taking, it sounds like a few big insurance networks, not everybody yet. Is that also expanding?
Yeah, definitely keep expanding into different insurances. And our website if you come to www.twochairs.com, it'll have all that there. It'll let you know. And we have a care coordination team that can help you figure out your insurance coverage. And so if we're out of network, they can help you think about what the cost share might be for you. We also obviously take self-pay. If somebody wants to come on their own, they can do that. And you can book your consult appointment on the website directly. So they can come straight to the website and schedule their appointment.
So you don't have to call?
You don't have to, no.
Great for a lot of people out there who hate making phone calls. It's great when you can do that straight from the portal or the website or whatever.
Yeah, absolutely.
Okay. And so what does the process from the client side look like? Does it start with Obviously, you might do care coordination to figure out if you can do this, but then are there assessments that they're doing before they meet with somebody? How does that look?
Yeah. So the way it would happen is you'd come on the website, fill out the information it asks for, and then it books your appointment. And then you'll get some emails around, thank you for booking your appointment. And then also some links to some pre-work to fill out before your first session. If you don't fill it out before your first session, your consult clinician will walk through that with you in session, but it's starting those clinical measures. So you're going to fill out a measure on depression and a measure on anxiety to start with. And then once you are with your consult therapist, they sort of take over all the other things there. And then your ongoing therapist, you'll be scheduled from the consult appointment. You and the consult clinician will talk about your schedule. So let's say you want a Monday at 9 appointment, then you'll get scheduled into a Monday at 9 appointment for as long as your treatment is, so that you always have that same spot. And then every therapy appointment before you come to therapy, you'll fill out those similar measures, the Alliance measure, the depression, anxiety, and the quality of life measure too.
Are those sent to your email or whatever? Is it an app or is it email?
It's an email. We have a client app too that we're building out, but right now most of it is done through email.
Is the intake session, is that a paid session?
Yeah. Yeah. And and insurance covers those too.
Cool. Okay. Anything else that you think people should know about the platform as they're sort of considering if they might be a candidate for this?
Just our care coordination team is there to answer any questions anytime. So you can reach out and ask about any details that you might have for sure. But I think that high level covers it.
Yeah. And I guess lastly, I would want to ask, for you personally, is there anything that you are excited about on the horizon, whether it's with Two Chairs specifically or where the field is going? Is there anything that you personally are kind of looking forward to?
Yeah, well, I definitely love that we're moving towards measurement, because I think forever it's been really hard, both as a therapist, to know, am I actually improving things? I think I am, but how do I know? And when more and more we're adding measurement at Two Chairs to other conditions, not just depression, anxiety, and quality of life, but how do we think about all the other conditions that we have? That's, I think, really important, both for clients and for clinicians and for the market and the payers. Sort of if I was going on a weight loss program and no one was actually weighing me or measuring me, then how would I know if this is working? So I like that. I also love the influence that we're seeing with more and more of the cultural responsive training and the DEIB awareness. We added a senior manager of DEIB a year and a half ago, Aubrey Harrison. He's a clinical psychologist and he's our DEIB leader. And that's really been transformative for both our clinical team being able to understand nuances, but also really providing culture responsive treatment, I think, is really important, and thinking about how do you do that for individuals.
I saw on the website, it said something, I don't know the exact figure, is over 40% of clinicians are non-white, I think, right?
Yeah, they're BIPOC. Yeah, and we also have a large representation of LGBTQ2+. And part of that is because I do think when you think about that safe space and feeling non-judged, sometimes it just starts with someone's lived experience, someone feeling seen and represented in the person on the other side of the screen. Not for everybody, but for some. And so being able to provide both a panel that looks like them and has lived experience like them, but also training the rest of the team to really be culturally aware of what might be coming up for somebody, so that we can provide the best support we can.
Yeah. It sounds like you've done a really good job, influencing the company and moving things in a great direction. So I'm glad that you're on that team, and it sounds like a really cool platform. So where do people access this? This is just twochairs.com. How do people reach out?
Yeah, twochairs.com is the best place to start. There's phone numbers there and care coordination things, but also you can just sign up for your consult there too.
Awesome. Well, I think we can wrap it there. This always happens when I'm talking to another therapist. Somehow it just goes to 50 minutes and then we like naturally, taper off because there's that internalized sense of, session time.
That's funny.
But I really appreciate your time. Is there anywhere aside from Two Chairs that people can follow along with you? Are you out there at all?
So we're on LinkedIn. I'm on LinkedIn. I talk about therapy related stuff a lot on LinkedIn, so people can certainly follow me there. And Two Chairs is on LinkedIn too, so you'll see some of the press that I'm in on our Two Chairs website or LinkedIn page as well.
LinkedIn.
Yeah.
Awesome.
Cool.
Well, thank you for your time. I appreciate it.
Yeah, thank you so much. It was great meeting you.